Picture a clinical scenario for a second. You get called out to a scene to evaluate a deceased individual, and the victim has suffered a fatal penetrating stab wound directly to the chest.
Right.
It's a severe injury, clearly tracking right through the thoracic cavity. It could have breached the heart or maybe the descending aorta. But as you examine the immediate environment, the floor, the victim's clothing, the surrounding walls, there is an absolute absence of blood, none whatsoever.
Yeah, and your initial instinct there might be to assume the scene has been thoroughly cleaned, or maybe the body was transported post-mortem.
Exactly. But there is actually a purely physiological explanation embedded within the regional anatomy of the human thorax. The body just doesn't absorb physical trauma in a uniform manner. It maps the mechanism of that trauma according to the specific anatomical and physiological properties of the region involved.
That scenario really highlights the fundamental premise of forensic pathology and even clinical traumatology. Location dictates the entire pathology. I mean, a mechanical force applied to the soft tissue of the thigh produces a vastly different physiological crisis than the exact same force applied to the anterior neck or the precordium.
Right, which brings us to our focus for today. We are shifting from evaluating isolated wounds to interpreting spatial relationships and anatomical patterns. We want to look at how regional anatomy fundamentally alters the expression of physical force and, critically, how those altered expressions translate into medico-legal evidence.
And that translation is everything.
It is. So we are embarking on a comprehensive deep dive into Chapter 10 of Simpson's Forensic Medicine, covering regional injuries and patterns of injury. But before we delve into the biomechanics of trauma, I need to state something very clearly to you. This deep dive is a conceptual exploration designed to support your reading of the text. It is high yield and memory anchored for exam prep and clinical revision, but it is not a replacement for reading the actual chapter in Simpson's. Grab your book, and let's use this to build your conceptual frameworks.
The intention here is to integrate the raw pathology with the physiological mechanisms and the eventual scene findings. Just rote memorization of injury lists, it's insufficient, for both clinical practice and forensic interpretation. Understanding the underlying biomechanics, why a specific tissue fails under a specific type of load that allows you to reverse engineer the event.
And that level of reasoning is exactly what stands up to scrutiny in a courtroom or an exam setting. So let's unpack this. Let's begin with the cranial vault. Specifically, the protective layers, the scalp, and the skull. The scalp is frequently underestimated in its clinical and forensic significance. It's often viewed merely as a superficial covering.
Which is a mistake. It's specific anatomical layered structure, the skin, dense connective tissue, the glia ponderotica, loose areolar tissue, and the periosteum makes it a really unique diagnostic site.
Especially that dense connective tissue layer.
Exactly. It's particularly crucial because it contains a highly rich anastomosing network of blood vessels. When these vessels are severed, the dense, fibrous nature of the surrounding tissue actually prevents them from retracting and undergoing vasospasm.
Right, and vasospasm is the body's normal hemostatic mechanism.
Precisely. Consequently, scalp wounds bleed profusely. In controlled clinical environment, you manage this with direct pressure and suturing. But in a forensic context, this ongoing hemorrhage takes on lethal significance.
Consider an individual who sustains what looks like a relatively minor scalp laceration, but they are concurrently acutely intoxicated with central nervous system depressants. Or perhaps they've collapsed outdoors in a hypothermic environment. That profuse, unabated bleeding can drive the patient into hypovolemic shock.
Yeah, and ultimately cause death from an injury that would otherwise be entirely survivable. Furthermore, the positioning of the body post-mortem heavily influences the scene. If the head is in a dependent position resting lower than the torso, gravity facilitates continuous oozing of blood from those non-retracting scalp vessels long after cardiac output has ceased.
Which can create a massive volume of blood at the scene.
It does, and that might initially mislead an investigator into suspecting a far more catastrophic internal injury or maybe a multi-strike assault.
Examining the scalp also presents unique physical challenges for the pathologist. Dense hair can easily obscure significant trauma, from subtle contusions to patterned abrasions. A visual scan just isn't enough. You need systematic palpation to detect boggy swelling or underlying bone defects. And for definitive medico-legal documentation, the scalp must be chased.
Shaving the area surrounding the wound is a non-negotiable step in forensic practice. Because the scalp tissue is tethered tightly to the underlying skull by the glia ponderotica, it tends to localize inflammatory fluid. When blunt force crushes the scalp, the resulting edema cannot diffuse easily into surrounding tissues.
It gets trapped.
Right. This results in prominent, highly localized swelling that can retain the physical imprint of the striking object. If an assailant uses footwear to stamp on a victim's head or strikes them with the heavy machined end of a flashlight, the shaved scalp might reveal a patterned contusion or abrasion.
And then that patterned injury can be photographed to scale and used for direct overlay comparison with a suspected weapon.
Exactly. Which brings us to a major diagnostic anchor distinguishing between a laceration and an incised wound.
This is a big one. In colloquial terms, any break in the skin is often called a laceration. People say, I lacerated my finger on a piece of paper. But in medico-legal terminology, conflating the two is a critical error. They imply entirely different weapons and mechanisms of injury.
An incised wound is the product of sharp force trauma, a scalpel, a piece of broken glass, a finely edged blade. The sharp edge cleanly divides the tissues, including the epidermis, dermis, and subcutaneous structures. It leaves sharp, uncrushed, and highly defined margins.
Whereas a laceration is fundamentally different. It is the physical manifestation of blunt force trauma.
Right. The skin is not cut. It is subjected to compressive and tensile strain until it mechanically tears apart. Because the tissue is tearing rather than being sliced, we look for the classic histological and macroscopic marker tissue bridging.
Tissue bridging, let's break that down.
When blunt force crushes the scalp against the rigid underlying calvarium, the softer, more friable adipose and connective tissues rupture. However, structures with higher tensile strength and elasticity, specifically blood vessels and nerve fibers, they often resist this tearing force.
They remain structurally intact. They stretch across the void of the wound like biological cables, finding those intact vessels bridging the depth of the wound, accompanied by crushed, abraded, or macerated epithelial margins, definitively categorizes the injury as a laceration caused by a blunt impact.
It's important to note, though, because the scalp is stretched so tightly over the convex surface of the skull, a blunt impact can sometimes cause the skin to split in a remarkably straight line. It can mimic the appearance of an incised wound.
Which is why a superficial visual inspection is inadequate. You have to use magnification and physically separate the wound edges to search for those deeper tissue bridges. Now, the mechanism of the skin failing leads us directly to the structure beneath of the skull. The cranial vault is a highly engineered rigid container. It's got an inner and outer table of compact bone separated by spongy diplo. It's designed to dissipate force.
Meaning it has a certain degree of viscoelasticity. It can temporarily deform and rebound, but the threshold of that deformation is the elastic limit. When the kinetic energy delivered by an impact exceeds the skull's elastic limit, the structural integrity fails, resulting in a fracture.
And the morphology of that fracture provides a direct biomechanical readout of the energy transfer.
Yes. A linear fracture is the most common. It typically results from a broad impact that causes the skull to bend inward at the point of contact and bow outward at the periphery. The bone fails at the point of maximum outbending, creating a linear crack that propagates toward the point of impact and often down toward the base of the skull.
But when we examine extreme high-energy transfers, like a high-speed road traffic collision or a fall from a significant height, the force dictates a more catastrophic failure pattern, like the hinge fracture.
A hinge fracture occurs when massive force propagates bilateral fractures across the base of the skull. They typically meet in the midline and traverse the structurally weaker pituitary fossa. This effectively cleaves the base of the skull into two separate halves, allowing the anterior and posterior sections to move independently.
Acting quite literally like a hinge.
Exactly. It is a marker of immense, usually instantly fatal kinetic energy.
Another highly specific pattern driven by kinetic energy transfer is the ring fracture. That's located around the foramen magnum. This is an excellent example of force transmission through the skeletal axis.
The foramen magnum is the large aperture at the base of the occipital bone where the brainstem transitions into the spinal cord. A ring fracture here occurs when the cervical spine is violently driven upward into the base of the skull. You classically see this in victims who fall from a height and land squarely on their feet or buttocks.
The kinetic energy travels vertically up the axial skeleton and punches the cervical spine right into the occiput.
Yeah, or conversely, the same fracture can occur if a heavy weight drops directly onto the vertex of the skull, driving the cranium down onto the rigid cervical spine.
Moving from indirect axial force back to direct blunt trauma, we have the spider's web fracture. This implies a broad, flat, impacting surface.
If the head strikes a flat, unyielding surface like a concrete floor or a wide wall, the impact energy is distributed over a large area. The bone fails in multiple radiating lines extending outward from the central point of impact. Simultaneously, the inward depression of the skull causes concentric circular fractures to form, intersecting those radiating lines.
And the resulting pattern visually mimics a spider's web. Contrast that broad energy dissipation with a localized, highly focused impact, which produces a depressed skull fracture. This is where the skull's bilayer construction really becomes mechanically relevant.
When a localized object with high kinetic energy, like a hammer or a heavy metallic pipe, strikes the skull, it imparts massive force onto a very small surface area. This overcomes the bone's structural resistance instantly, driving a localized section of the bone inward.
Because the inner table of the skull is inherently thinner and more brittle than the outer table, it tends to fragment much more extensively.
And those sharp bony shards can be driven through the meninges and directly into the underlying cortical tissue. The outer table defect, however, will frequently retain the curved outline or distinct geometric profile of the weapon's striking surface. It acts as a rigid, negative mold.
The final fracture pattern to consider operates almost entirely via force transmission rather than direct impact, the blowout fracture of the orbital plates. The bony roof of the orbit is incredibly thin, almost translucent in places.
A direct blow to the globe of the eye will rapidly increase intraorbital pressure, causing the weakest boundary, the orbital floor or roof, to blow out and fracture. However, these fractures also frequently occur secondary to a severe impact to the back of the head.
The energy wave propagates through the dense bone of the skull base and dissipates by blowing out those fragile orbital plates. Finding bilateral orbital roof fractures in a patient who sustained an occipital impact is a classic finding that speaks to the propagation of kinetic energy through the cranial vault.
As the text emphasizes, while skull fractures provide invaluable reconstructive data, the fracture itself is rarely the immediate mechanism of death. Humans can survive extensive linear skull fractures. The physiological threat lies in the transmission of that force to the vulnerable structures enclosed within.
Which means we must consider the cranial vault as a closed, rigid box.
That concept is known as the Monro-Kelly hypothesis. The cranial vault contains three essentially incompressible components: brain parenchyma, cerebrospinal fluid, and intravascular blood. Because the overall volume of the vault is fixed, any increase in the volume of one component must be compensated for by a decrease in the volume of another.
So if a traumatic event introduces a new pathological volume, like an expanding hematoma, the cerebrospinal fluid and venous blood are initially displaced. This is the body's compensatory phase.
But those compensatory mechanisms have a strict physiological limit. Once that threshold is crossed, the intracranial pressure, or ICP, begins to rise exponentially. This directly threatens cerebral perfusion pressure.
If the intracranial pressure rises to equal the mean arterial blood pressure, oxygenated blood can no longer be pushed up into the brain against the resistance. Global cerebral ischemia ensues.
And the anatomical location of the bleeding vessel dictates the timeline and presentation of this rising pressure. Let's look at an extradural or epidural hemorrhage. This occurs in the potential space between the inner table of the skull and the tough, fibrous dura mater. The space is highly vascularized by the meningeal arteries.
Most notably, the middle meningeal artery, which runs in grooves along the inner surface of the squamous temporal bone. The proximity of the middle meningeal artery to the thin temporal bone makes it highly susceptible to mechanical shearing if a linear fracture crosses its path. And because it's an artery, the blood is under high systolic pressure.
Right. When the middle meningeal artery is torn, it pumps arterial blood forcefully into the extradural space. The dura mater is tightly adhered to the skull, particularly at the suture lines. The high-pressure arterial bleeding acts as a mechanical wedge, physically stripping the dura away from the bone as the hematoma expands.
This specific biomechanical progression results in one of the most recognizable clinical presentations in emergency medicine, the lucid interval.
Following the initial traumatic impact, the patient may experience a brief loss of consciousness due to the concussive force. They then regain consciousness and appear neurologically intact, alert, and communicative. This is the lucid interval.
It represents the compensatory phase we discussed earlier. The hematoma is actively expanding, stripping the dura, but the brain is compensating by shifting CSF and venous blood. The patient might even refuse medical attention, feeling relatively normal.
But the arterial pump does not stop. Once the compensatory reserve is exhausted, the expanding extradural mass begins to rapidly compress the underlying brain tissue. The neurological decline is catastrophic and precipitous. The patient transitions from awake and alert to confused, then comatose, exhibiting unilateral pupillary dilation as the expanding mass compresses the third cranial nerve.
Followed by hemiparesis and abnormal posturing. Without immediate neurosurgical intervention to evacuate the clot and ligate the bleeding artery, the rising intracranial pressure leads inevitably to fatal brainstem compression.
Moving deep to the duramater, we encounter the subdural space. The pathophysiology here shifts from high-pressure arterial bleeding to lower-pressure venous bleeding, fundamentally altering the time frame and mechanism of injury.
The subdural space is traversed by bridging veins. These vessels drain venous blood from the cerebral cortex, crossing the subarachnoid and subdural spaces to empty into the large dural venous sinuses attached to the skull. Unlike the meningeal arteries, bridging veins are rarely injured by localized skull fractures.
Their vulnerability lies in their viscoelastic response to sudden motion. They are susceptible to rotational acceleration and deceleration forces. When the head is subjected to sudden, violent movement, the rigid skull moves immediately. However, the brain, suspended in cerebrospinal fluid, possesses inertia and lags slightly behind.
This differential movement creates massive shearing forces across the bridging veins.
The veins are stretched beyond their tensile limits and rupture, spilling venous blood into the subdural space. Because it is a venous bleed, the pressure is significantly lower than in an extradural hematoma. The blood tends to ooze and spread widely over the convex surface of the cerebral hemisphere rather than forming a tightly focal, deep pocket.
The mechanism of bridging vein rupture is also heavily influenced by underlying neuroanatomy, specifically cerebral atrophy. This explains the classic demographic pattern of chronic subdural hematomas.
As the human brain ages, or in the context of chronic alcohol dependency, the brain parenchyma gradually atrophies, decreasing in total volume. Because the skull volume remains fixed, this atrophy increases the distance between the cerebral cortex and the inner surface of the duramater.
Consequently, the bridging veins are placed under chronic tension. They are stretched taut across this expanded space. In this heightened state of tension, it requires significantly less kinetic energy to cause a rupture.
A minor impact, a fall from standing height, or even a bump against a doorframe that the patient may not even recall can be sufficient to snap a bridging vein. Because the bleed is low pressure and the atrophied brain provides additional space within the cranial vault, the intracranial pressure rises very slowly.
The patient might not exhibit acute neurological symptoms for days, weeks, or even months. They might present with subtle, progressive cognitive changes, recurrent headaches, or a fluctuating level of consciousness.
When a pathologist examines a subdural hematoma, determining its age is vital for reconstructing the timeline of events. An acute subdural presents as a collection of dark red, clotted, or fluid blood. But as it transitions into a chronic state, cellular degradation occurs.
The body initiates a complex inflammatory and resorptive response. Macrophages infiltrate the hematoma to phagocytize the degenerating red blood cells. The hemoglobin is broken down and the iron is stored within these macrophages as a complex called hemosiderin.
Macroscopically, the older blood turns a dark brown, motor oil-like fluid. The body also attempts to wall off the bleed, proliferating fibroblasts to form a thick, gelatinous, and eventually tough, rubbery membrane around the hematoma.
The microscopic presence of hemosiderin is a crucial medico-legal dating tool. Pathologists utilize Pearl's Prussian blue stain, which specifically reacts with iron, turning hemosiderin-laden macrophages a vibrant blue. Finding these cells confirms that the bleeding event occurred at least several days prior.
It provides objective, temporal evidence independent of witness testimony.
Descending further, we reach the subarachnoid space, located between the arachnoid mater and the pia mater that closely invests the brain surface. This space contains the cerebrospinal fluid and the major cerebral arteries comprising the circle of Willis. Subarachnoid hemorrhage can be a secondary finding in severe contusional head trauma, but isolated, massive basal subarachnoid hemorrhage demands rigorous investigation.
You have to differentiate natural disease from trauma. Spontaneous rupture of a saccular or berry aneurysm, a localized weakness in the arterial wall within the circle of Willis, is a classic natural cause of sudden death. It floods the basal cisterns with high-pressure arterial blood. However, a highly specific mechanical trauma can mimic this exactly.
We must consider the biomechanics of the upper cervical spine and its relationship to the vertebral arteries. The vertebral arteries ascend through the transverse foramina of the cervical vertebrae. As they exit the axis and atlas, they make several sharp anatomical turns before piercing the duramater to enter the cranial cavity through the foramen magnum.
If an individual sustains a forceful impact to the side of the upper neck or a blow just postero inferior to the ear, it induces a violent, sudden rotation and lateral flexion of the head. This extreme rotational acceleration puts immense tensile stress on the vertebral arteries, exactly where they are tethered and vulnerable as they enter the skull.
The sudden stretch can cause an intimal tear or a complete transmural rupture of the vertebral artery, usually within its intracranial segment. This results in an immediate, explosive arterial hemorrhage into the basal subarachnoid space, leading to rapid death.
Differentiating between a ruptured berry aneurysm and a traumatic vertebral artery tear requires highly specialized autopsy techniques. The standard brain removal is insufficient. The pathologist must conduct a meticulous, bloodless dissection of the deep neck structures, carefully exposing and removing the entire cervical and intracranial segments of both vertebral arteries.
They examine them microscopically to locate the precise site of the traumatic tear. The distinction is the difference between ruling a death natural or a homicide.
Having explored the vascular disruption around the brain, we must now examine the pathological forces acting upon the brain parenchyma itself, traumatic brain injury, or TBI. It is clinically and forensically useful to divide TBI into primary and secondary injury phases.
Primary TBI encompasses the immediate mechanical damage sustained at the moment of impact. Cortical contusions, lacerations from depressed bone fragments, and the immediate severing of neuronal pathways. Secondary TBI refers to the cascade of physiological and biochemical events initiated by that primary trauma.
And this cascade is often the ultimate cause of morbidity and mortality. We return again to the rigid constraint of the cranial vault and the consequence of cerebral edema. Following significant mechanical trauma, the blood-brain barrier is often disrupted. This allows plasma, proteins, and fluid to leak into the interstitial space of the brain, a process known as vasogenic edema.
Concurrently, injured neurons and glial cells experience a failure of their ATP-dependent sodium-potassium pumps. Sodium accumulates intracellularly, drawing water into the cells via osmosis, resulting in cytotoxic edema. Both mechanisms unequivocally increase the physical volume of the brain tissue.
Because the skull cannot expand outward to accommodate the swelling, the brain is forced to expand inward, compressing its own vascular supply and shifting its anatomical position within the dural partitions. This physical displacement is known as herniation.
As intracranial pressure mounts, the path of least resistance directs the swollen tissue downward. The uncutus, the medial portion of the temporal lobe, is forced medially and downward over the rigid free edge of the tentorium cerebelli. This uncal herniation compresses the third cranial nerve and the midbrain.
If the generalized pressure continues to rise, the cerebellar tonsils are driven forcefully down into the narrow funnel of the foramen magnum. This tonsillar herniation, colloquially known as canun, exerts catastrophic compressive force directly onto the medulla oblongata,
The lower half of the brainstem that houses the autonomic control centers for respiration and cardiac function. When the medulla is crushed, central respiratory drive ceases, leading to terminal anoxia. At autopsy, the gross pathology of generalized edema is striking. The brain is abnormally heavy, the surface gyri are flattened tightly against the inner table of the skull, the sulci are obliterated, and upon coronal sectioning, the normally fluid-filled lateral ventricles are compressed into narrow, slit-like potential spaces.
While gross edema and contusions are macroscopically obvious, one of the most devastating forms of TBI occurs at the microscopic level, diffuse axonal injury, or DAI. To understand the pathogenesis of DAI, we must appreciate the macroscopic structure of the brain. It is not a homogeneous sphere. It is highly compartmentalized into gray matter, white matter tracts, and fluid-filled ventricles, each possessing different specific gravities and viscoelastic properties.
When the head is subjected to high-energy angular or rotational acceleration and deceleration, such as the violent whipping motion experienced by an unrestrained occupant in a vehicular rollover, these different anatomical compartments do not move synchronously.
The gray matter and white matter slide over one another. This differential movement generates immense internal shearing forces deep within the brain substance. The primary victims of this shear are the axons, the long, delicate projections of neurons that form the white matter tracts, responsible for transmitting electrical impulses across different brain regions. The sheer mechanical force stretches, twists, and physically disrupts the axonal cytoskeleton.
DAI is the pathophysiological foundation of severe concussive syndromes. It can result in immediate, profound coma and death, even in the complete absence of skull fractures, epidural hematomas, or macroscopic cortical contusions. So what does this all mean for a pathologist at the microscope?
Well, the challenge for the forensic neuropathologist is that an acutely severed axon is essentially invisible to the naked eye, and it's not immediately apparent even under standard microscopic examination. The forensic detection of DAI relies entirely on understanding the biology of axoplasmic transport.
Within a healthy axon, there is a continuous motor protein-driven transport system moving essential cellular materials from the neuron cell body down to the synaptic terminal. When the axonal cytoskeleton is mechanically damaged by shearing forces, this internal transport system is abruptly halted.
However, the cell body continues to synthesize and pump these proteins into the proximal stump of the axon. Because the transport highway is broken, these proteins begin to accumulate and pool at the exact site of the disruption, creating a microscopic dam.
The most reliable marker for this interruption is the accumulation of beta-amyloid precursor protein, or beta-APP. Using specialized immunohistochemical staining techniques, pathologists can target beta-APP. Under the microscope, areas of axonal injury will exhibit distinct brown focal accumulations of beta-APP within the white matter tracts, particularly in the corpus callosum and brainstem.
Crucially, this accumulation operates on a strict physiological timeline. It requires the patient to survive the injury for a minimum of roughly 2 to 3 hours for a sufficient detectable quantity of beta-APP to pool at the injury site.
If the patient survives longer, upwards of 12 to 24 hours, the accumulating proteins and organelles cause the damaged end of the axon to swell into a visible spherical mass known as a retraction bulb, which can be visualized using traditional silver stains or hematoxylin and eosin.
The presence of beta-APP or retraction bulbs is a powerful temporal anchor. If a pathologist identifies these markers, it definitively proves that the traumatic event occurred hours prior to cardiac death. It provides objective data to validate or refute complex timelines in criminal investigations.
It's important to interpret these findings carefully, as severe global hypoxia can also interrupt axoplasmic transport and cause beta-APP accumulation, necessitating a holistic view of the case. The mechanical disruption of axons leads naturally into the discussion of repetitive mild traumatic brain injury and the emerging understanding of chronic traumatic encephalopathy, or CTE.
Historically categorized as dementia pugilistica or punch-drunk syndrome in boxers, CTE is a progressive neurodegenerative disease triggered by repeated subconcussive or concussive impacts. The initial mechanical trauma, even if mild, initiates a cascade of progressive cytoskeletal deterioration.
The pathological hallmark of CTE is not beta-APP, but rather the abnormal accumulation and deposition of hyperphosphorylated tau protein. Tau is normally a stabilizing structural protein for microtubules within neurons. However, repetitive trauma causes the tau protein to misfold, detach from the microtubules, and aggregate into toxic neurofibrillary tangles and astrocytic tangles.
These tau aggregates cluster in a highly specific, topographically distinct pattern. They're typically distributed paravascularly and deeply within the sulci of the cerebral cortex. This pattern clearly differentiates CTE from other neurodegenerative diseases like Alzheimer's.
The implications are profound. We are identifying advanced CTE in the brains of American football players, combat veterans exposed to blast over pressure waves, and increasingly soccer players exposed to the repetitive low-velocity trauma of hitting the ball. This presents a monumental shift in liability and sports safety protocols.
We are discovering that repetitive microtrauma, previously considered benign, acts as a definitive catalyst for severe delayed neurodegeneration. Currently, definitive diagnosis requires post-mortem neuropathological examination, but the medical and legal frameworks are actively evolving.
Returning to acute biomechanics, we must examine the spatial relationship between the point of impact and the location of internal brain injury. This brings us to the fundamental forensic paradigm of coup versus contra-coup injuries. Understanding these patterns is essential for determining the dynamic state of the victim's head at the moment of impact.
Let's build the classic model. A coup injury is a cerebral contusion located directly subjacent to the site of the external impact. The mechanical force deforms the skull inward, bruising the underlying cortical tissue. The scalp laceration, the skull fracture, and the brain contusion all align on the same anatomical axis.
Coup contusions are the hallmark of an impact to a stationary supported head. If an individual is standing still and is struck violently with a heavy object, a baseball bat, for example, the energy is transferred directly through the bone into the immediately underlying brain tissue, resulting in a coup injury.
In contrast, a contra-coup injury occurs when the cerebral contusion is located on the burn surface diametrically opposite to the point of external impact. This specific pattern is the signature of a moving head impacting a stationary, unyielding surface.
Consider the biomechanics of an assault resulting in a fall. An individual receives a blow to the face, loses their balance, and falls backward. The occipital region of their moving head violently strikes the concrete ground. At the exact millisecond of impact, the rigid skull abruptly decelerates and stops.
However, the brain, floating in its cerebrospinal fluid bath, possesses independent forward momentum. It does not stop instantly. The brain continues its trajectory within the cranial vault for a fraction of a second. As it shifts away from the occipital impact site, it creates a transient pressure gradient, essentially a localized negative pressure or cavitation effect at the rear.
More significantly, the frontal and temporal poles of the brain are driven forcefully into the anterior and middle cranial fossa. The inner surfaces of the skull vault are relatively smooth, but the base of the skull, particularly the orbital roofs and the sphenoid wings, is highly irregular. It's characterized by sharp, bony ridges and rough prominences.
When the soft viscoelastic brain tissue glides aggressively over these rough, bony ridges under high inertial force, it sustains massive contusional tearing and hemorrhagic bruising. Therefore, a deceleration impact to the occiput results in devastating contra-coup contusions on the undersurfaces of the frontal and temporal lobes.
The primary impact site at the back of the head may present with only a superficial scalp abrasion or a minor linear fracture, completely masking the catastrophic injury at the opposite pole. The medico-legal application of the coup-contra-coup paradigm is huge. Pathologists use these patterns to independently verify or refute witness testimony.
If a suspect claims they pushed the victim in self-defense, causing them to fall and hit their head, the pathologist expects to find significant contra-coup contusions on the inferior frontal and temporal lobes, indicative of a moving head deceleration impact.
If, however, the autopsy reveals a massive depressed coup contusion directly beneath a vertex skull fracture, with absolutely no contra-coup damage, the physical evidence flatly contradicts the narrative of a simple fall. The pathology indicates a high-energy blow to a stationary head, suggesting a direct assault with a weapon. The biomechanics of the injury provide an objective, independent account of the event.
Moving inferiorly from the cranium, we address the cervical region, the neck, and spine. The neck acts as a highly vulnerable, compact conduit containing critical physiological systems: the airway, the gastrointestinal tract, the spinal cord, and major vascular networks, all within a narrow cylinder possessing minimal structural protection.
Penetrating trauma to the neck carries incredibly high morbidity and mortality due to this dense packing of vital structures. When evaluating incised wounds to the neck, forensic pathologists rely on pattern recognition to differentiate between self-inflicted injuries and homicidal assaults.
The patterns are largely dictated by intent and motor control. Self-inflicted incised wounds typically present with hesitation marks, multiple, shallow, superficial cuts adjacent to or within the primary deep incision. These reflect tentative attempts before the fatal application of force.
Furthermore, the angle and direction of the wound tract often align with the victim's dominant handedness, sloping downward from the side opposite the dominant hand. Homicidal assaults involving sharp force to the neck generally lack hesitation marks, presenting as a single or multiple deep, forceful incisions.
Crucially, assault victims frequently present with defensive wounds, incisions or stabs on the palmar aspects of the hands, fingers, or ulnar forearms. These are sustained while attempting to ward off the weapon or grasp the blade.
The physiological consequence of severing major cervical vasculature dictates the scene presentation. If a major high-pressure vessel like the carotid artery is transected, the heart continues to pump aggressively, expelling arterial blood under high systolic pressure through the defect.
This creates a distinct dynamic blood spatter pattern known as arterial spray or arterial rain. The oscillating pressure of the cardiac cycle creates a pulsatile spurting pattern on adjacent walls or surfaces. Blood stain pattern analysts can interpret this to reconstruct the specific positioning and movement of the victim at the time the artery was breached.
However, if the trauma isolates a major cervical vein, such as the internal jugular, the physiological crisis is entirely different and often lacks massive external hemorrhage. Venous pressure in the head and neck is significantly lower than arterial pressure, and depending on posture and respiratory phase, it can actually drop below atmospheric pressure.
When a person inspires deeply, the diaphragm drops, creating negative pressure within the thoracic cavity to draw air into the lungs. This negative pressure is transmitted up the venous system to the neck. If the jugular vein is severed, this negative pressure gradient can suck ambient air directly into the open lumen of the vein.
This entrained air travels rapidly down the superior vena cava and into the right atrium and right ventricle of the heart. The mechanical action of the right ventricle churning this mixture of blood and air creates a dense, frothy airlock.
This frothy mixture is highly compressible. The right ventricle fails to generate sufficient pressure to push this airlock through the pulmonary circulation. Cardiac output drops to zero instantaneously. This is a massive cardiac air embolism, resulting in rapid cardiovascular collapse and death, potentially with very little blood loss at the scene.
The structural core of the neck and torso is the spinal column. It is an extraordinary feat of biomechanical engineering, designed to support significant axial loads while maintaining flexibility. Structurally, it's highly resilient against compressive forces along its vertical axis. However, it is fundamentally vulnerable to sudden, extreme angulation or bending forces.
To evaluate spinal stability post-trauma, clinicians and pathologists employ the Dennis three-column model. This conceptual framework divides the vertebral column into the anterior column, the middle column, and the posterior column.
The anterior column contains the anterior longitudinal ligament and anterior half of the vertebral body. The middle column has the posterior half of the vertebral body and the posterior longitudinal ligament. And the posterior column contains the neural arch, pedicles, and posterior ligamentous complex. The integrity of the middle column is paramount.
If a traumatic force disrupts only the anterior or posterior column, the spine often remains mechanically stable. However, if the middle column fails, or if two or more columns are disrupted, the spine becomes acutely unstable. This drastically increases the risk of the vertebrae shifting and transecting or compressing the enclosed spinal cord.
Let's examine specific loading mechanisms and their resulting fracture patterns. Hyperextension involves the violent, extreme backward bending of the cervical spine. This is the classical mechanism in a whiplash injury during a rear-end motor vehicle collision where the torso is accelerated forward while the unsupported head whips backward, placing massive tensile stress on the anterior longitudinal ligament and compressive stress on the posterior neural arches.
Historically, severe hyperextension combined with extreme axial distraction was the precise biomechanical mechanism designed for judicial hanging via the long drop method.
The drop distance was meticulously calculated based on the condemned individual's mass. The objective was to generate sufficient kinetic energy to cause a sudden, violent hyperextension of the neck at the end of the drop.
This specific loading pattern typically fractures the pars interarticularis of the C2 vertebra, the hangman's fracture, and ruptures the ligaments connecting the atlas to the axis, resulting in massive distraction of the upper cervical spine and immediate disruption of the vital respiratory centers in the brainstem.
Conversely, hyperflexion forces extreme forward bending produce a different structural failure. Consider a scenario where an immense downward force is applied to the upper back or head while the individual is leaning forward, such as a roof collapse in a mine or a severely collapsed rugby scrum.
The force violently drives the anterior portions of the vertebral bodies together. The bone fails under the intense compressive load, resulting in anterior wedge compression fractures. If the force is severe enough, it can also tear the posterior ligamentous complex, creating an unstable fracture dislocation that threatens the spinal cord.
Lateral flexion or severe rotational forces introduce complex shearing dynamics. These forces attempt to twist the interlocking facet joints beyond their anatomical limits, frequently resulting in unilateral or bilateral facet dislocations. One vertebral body shears horizontally across the other, severely narrowing the spinal canal and often causing catastrophic transection of the spinal cord.
This biomechanical vulnerability emphasizes why rigorous cervical spine immobilization is the immediate priority for emergency medical personnel at any trauma scene. If a patient harbors an unstable cervical fracture, the seemingly benign act of tilting their head to clear the airway can cause the fractured vertebral bodies to shift, driving sharp bony margins directly into the spinal cord, converting a reversible skeletal injury into permanent quadriplegia.
Detecting these complex spinal injuries at autopsy requires specialized, meticulous dissection techniques. A standard visual inspection of the anterior spine is insufficient. The pathologist must perform layer-by-layer anatomical dissections of both the anterior and posterior muscular compartments of the neck to expose deep hematomas, ligamentous ruptures, and subtle, highly localized fractures, particularly around the complex atlanto-occipital articulation.
Continuing our descent, we address the thorax, the chest cavity. The mechanics of the chest are best understood through the principle of Boyle's law and pressure gradients. The thoracic cavity functions essentially as a set of biological bellows. For inspiration to occur, the diaphragm must contract downwards and the intercostal muscles must expand the rib cage outwards.
This expansion increases the internal volume of the thoracic cavity, thereby dropping the intrathoracic pressure below atmospheric pressure. This negative pressure gradient is the vacuum that physically pulls ambient air down the trachea and into the lungs. Any traumatic mechanism that restricts this expansion or breaches the sealed vacuum causes the bellows to fail, leading to asphyxia.
We must carefully delineate between traumatic asphyxia and positional asphyxia. Traumatic asphyxia, or crush asphyxia, is a purely mechanical failure caused by overwhelming external compression. If a massive weight, such as a collapsed structure or the extreme pressure of a crowd crush, pins the chest wall, the inspiratory muscles are physically incapable of overcoming the resistance to expand the rib cage.
The immense external pressure also exerts a retrograde force on the venous system. It squeezes blood out of the right side of the heart and the superior vena cava, forcing it backward up into the valveless veins of the head and neck. This sudden massive venous engorgement causes the delicate capillary beds in the conjunctiva, face, and neck to rupture, producing the dense pinpoint petechial hemorrhages that are the pathological hallmark of traumatic asphyxia.
Positional asphyxia, however, is a more insidious failure of the respiratory mechanics. It occurs when an individual's body position prevents adequate diaphragmatic and thoracic excursion. This is frequently encountered in individuals rendered unconscious or severely incapacitated by alcohol or drug intoxication.
They may slump forward, hyperflexing their neck and compressing their airway, while the weight of their own torso presses down on their diaphragm. Because their central nervous system is profoundly depressed, they lack the autonomic reflex to shift their posture. They slowly suffocate due to an inability to maintain the mechanical work of breathing against their own body weight.
Focusing on direct blunt force trauma to the chest wall, we evaluate rib fractures. Isolated rib fractures in a healthy adult are painful but generally uncomplicated. The biomechanical threat escalates dramatically with multiple contiguous fractures, specifically the condition known as a flail chest.
A flail chest occurs when 3 or more adjacent ribs are fractured in at least 2 places along their length. This structural failure completely detaches a segment of the chest wall from the bony continuity of the rib cage. This loss of structural integrity destroys the mechanics of the bellows, resulting in paradoxical respiration.
When the patient attempts to inhale, the thoracic volume expands, generating the necessary negative intrathoracic pressure. However, instead of pulling air into the lungs, this powerful vacuum pulls the physically detached flail segment of the chest wall inward. Conversely, during exhalation, the positive intrathoracic pressure pushes the flail segment outward.
The injured chest wall moves in direct opposition to the respiratory cycle, severely compromising tidal volume and rapidly leading to acute respiratory failure. Furthermore, the jagged, fractured ends of the ribs present an immediate penetrating threat to the underlying intrathoracic organs. A sharp bone fragment can easily lacerate the pleural membranes or the lung parenchyma itself.
If the lung tissue is breached, inspired air escapes from the alveoli into the pleural space, creating a pneumothorax. As air accumulates, the pressure in the pleural cavity rises, collapsing the delicate lung tissue and shifting the mediastinum, further compromising both respiration and cardiac output. If the fractured rib severs an intercostal artery, high-pressure blood rapidly fills the pleural space, resulting in a hemothorax, combining the physiological crises of respiratory restriction and massive hypovolemic shock.
The interpretation of rib fractures presents a critical challenge in forensic pathology, particularly distinguishing trauma inflicted during an assault from fractures sustained during emergency medical intervention, specifically cardiopulmonary resuscitation or CPR.
This distinction is a frequent point of contention in legal proceedings. Defense counsel may argue that the victim's death or severe chest injuries were caused not by the defendant's actions, but by the aggressive compressions performed by paramedics. The pathologist resolves this by analyzing the specific pattern and the vital reaction of the tissue.
The pattern of CPR-induced fractures is dictated by the biomechanics of chest compressions. The force is applied directly downward under the lower third of the sternum. Consequently, the ribs bend outward and typically fail anteriorly or anterolaterally near the costochondral junctions. Because the force is applied centrally, the resulting fractures are almost invariably symmetrical, occurring bilaterally across the chest wall.
The definitive distinguishing factor, however, is the presence or absence of a vital reaction, specifically hemorrhage. If the individual was in cardiac arrest when CPR was initiated, their heart was not generating any blood pressure. Therefore, when the ribs fracture during compressions, the torn tissues do not bleed.
A pathologist will observe clean fractures with minimal or completely absent surrounding soft tissue hemorrhage. In contrast, traumatic rib fractures sustained during an assault while the victim was alive and maintaining a perfusing blood pressure will present with extensive, deep hemorrhagic bruising infiltrating the surrounding intercostal muscles and parietal pleura.
Symmetrical anterior fractures lacking hemorrhage indicate post-arrest CPR. Asymmetrical, lateral, or posterior fractures with massive vital reaction indicate perimortem trauma.
Returning to the scenario posed at the very beginning of our discussion, the victim with a fatal penetrating stab wound to the chest but an absolute absence of blood at the scene. We can now fully explain this phenomenon through the regional anatomy of the thorax.
The thoracic cavity contains immense potential spaces, primarily the right and left pleural cavities that house the lungs. A single pleural cavity in an adult can easily accommodate 2 to 3 liters of fluid. When a sharp implement penetrates the chest wall, it creates a narrow tract through the skin and intercostal muscles.
If that blade breaches a major high-pressure structure, such as the myocardium of the heart, the ascending aorta, or the pulmonary trunk, the resulting hemorrhage is catastrophic.
However, the blood does not necessarily follow the narrow, restricted tract back out through the skin. Instead, it follows the path of least resistance, pumping forcefully inward into the vast, low-pressure void of the pleural cavity. The patient exsanguinates, bleeding to death entirely internally.
Because the blood volume is being lost into the chest cavity rather than onto the floor, the victim may retain sufficient cerebral perfusion to remain conscious and capable of complex motor function for several seconds to a few minutes.
They possess the physiological reserve to perform purposeful actions. They can engage in a struggle, they can flee the immediate area, traverse a hallway, or exit a building, leaving absolutely no external blood trail. They eventually succumb to hypovolemic shock and collapse at a secondary location.
The forensic takeaway is absolute. The lack of external bleeding at a scene never precludes the possibility that a fatal penetrating injury was sustained at that exact location. The internal anatomy hides the evidence. Moving to the final anatomical region, the abdomen. The biomechanics of abdominal trauma differ fundamentally from the chest because the abdomen lacks a protective anterior bony shield.
It is a highly compressible core of soft tissue, backed by the rigid anvil of the lumbar vertebral column. When a blunt force is applied anteriorly, such as a steering wheel impact or a forceful kick to the abdomen, the internal viscera are trapped. They are violently compressed between the impacting object and the unyielding mass of the spine.
We classify abdominal organs into solid and hollow viscera as their tissue architecture dictates their biomechanical response to this compressive load.
Solid organs, primarily the liver, spleen, and kidneys, are dense, highly vascularized parenchymal structures. When subjected to severe compression, their solid capsule and internal architecture exceed their elastic limits. They fracture, tear, or burst, resulting in immediate massive intra-abdominal hemorrhage.
Hollow viscera, such as the stomach, small intestine, and urinary bladder, act as closed fluid or gas-filled cylinders. Their failure mechanism is governed by Boyle's law.
If the loop of bowel is full of fluid or gas, and both ends are temporarily pinched closed by the compressive force, the sudden external pressure causes a massive instantaneous spike in intraluminal pressure. The bowel wall blows out, perforating and spilling its contents.
This spillage, highly acidic gastric juice or bacteria-laden fecal matter, induces a catastrophic chemical or infectious peritonitis, progressing rapidly to systemic sepsis. In addition to direct compression, the abdominal organs are highly susceptible to deceleration and rotational forces due to their anatomical attachments.
The spleen and kidneys, for example, are suspended within the abdominal cavity by their vascular pedicles, the hilum, which contain their critical arteries and veins. During a high-speed deceleration event, the torso is restrained by a seat belt, but the heavy solid organs continue their forward momentum, swinging violently like pendulums.
This immense shear force can avulse or completely tear the organ directly off its vascular pedicle. The organ itself may remain structurally intact, but its entire blood supply is transected, leading to rapid, fatal exsanguination into the retroperitoneal or peritoneal space. There's a highly specific, deceptive clinical presentation regarding splenic trauma that crosses over heavily into forensic timelines, the delayed rupture of the spleen. The spleen is encased in a relatively thin, fibrous capsule. Blunt trauma to the left upper quadrant can cause deep parenchymal lacerations within the spongy tissue of the spleen, initiating internal bleeding. However, the external capsule may remain remarkably intact. The bleeding continues, constrained by the capsule, forming an expanding subcapsular hematoma. The patient might present to an emergency department, exhibit stable vital signs, and complain only of localized manageable pain.
But the internal bleeding has not arrested. It slowly stretches the capsule over hours or days. Eventually, the accumulating pressure exceeds the tensile strength of the capsule. It ruptures catastrophically, releasing the pressurized hematoma and acute arterial bleeding directly into the peritoneal cavity.
The patient transitions from seemingly stable to profound hypovolemic shock and potential death days after the initial impact. This highlights the absolute necessity for rigorous serial clinical imaging and extended observation following significant abdominal trauma. We must also address a crucial, sobering medico-legal point regarding the force required to inflict these injuries.
In a healthy adult, fracturing a liver or crushing a duodenum requires massive kinetic energy, typically associated with severe motor vehicle collisions. The biomechanical threshold changes drastically in pediatric populations. Children possess smaller, thinner abdominal walls with less protective musculature and adipose tissue. Their internal organs are proportionately larger and less protected by the lower rib cage.
Consequently, the force required to inflict devastating visceral crush injuries or perforations is significantly lower. Furthermore, the mechanism does not always require high-velocity impact. Slow, intense, steady squeezing of a child's abdomen against the spine can produce these identical catastrophic crushing injuries.
If a pathologist encounters major intra-abdominal trauma in a pediatric patient, such as a transected pancreas or a ruptured bowel, without a highly credible, corroborated history of a major high-energy accident, it serves as an immediate, massive red flag for severe non-accidental trauma or physical abuse.
Finally, how does a pathologist establish a timeline for abdominal injuries if the patient survives for a period before succumbing? We return to the histological markers of peritonitis.
When a hollow organ perforates, the inflammatory cascade is triggered immediately, but the cellular manifestation takes time. It requires several hours for the acute inflammatory cells, specifically neutrophils, to migrate from the vasculature into the peritoneal tissue. Over subsequent hours and days, fibrin deposition occurs, organizing into fibrous adhesions.
By evaluating the microscopic density of the neutrophil infiltrate and the organization of the fibrinous exudate, a pathologist can reliably estimate whether the perforating injury occurred minutes, hours, or days prior to death, thereby locking in a biological timeline. Here's where it gets really interesting for your exams. We have extensively analyzed the physiological and biomechanical frameworks across multiple organ systems. To consolidate this knowledge, we will now transition into our learning reinforcement phase. Let's put this all together in a series of rapid, single best answer style prompts. I will present a specific patient presentation or pathological finding. Take a moment to consider the mechanism and the diagnosis, and then we will systematically break down the reasoning and link it back to the specific conceptual sections we have covered today. Prompt 1. You examine a scalp wound with crushed macerated edges and intact blood vessels crossing the depth of the wound. Is this a laceration or an incised wound? Take a second, got your answer.
It is a laceration. The key here is blunt trauma. Revisit the scalp injury section if you need a refresher on tissue bridging.
Prompt 2. A patient suffers a blow to the head and experiences a lucid period before rapid neurological decline. Which vessel is most likely injured, and what type of hemorrhage is this? Take a second to lock it in.
That would be the middle meningeal artery, leading to an extradural or epidural hemorrhage. Revisit intracranial hemorrhage for the Monro-Kelly hypothesis details.
Prompt 3. An elderly patient with a history of alcohol dependency is found dead. Autopsy reveals a firm, rubbery capsule of blood under the dura. What is the diagnosis? Think about the demographics.
Chronic subdural hematoma. Revisit intracranial hemorrhage, specifically the bridging veins and cerebral atrophy mechanism.
Prompt 4. A person falls backwards, striking the back of their head on the pavement. Where would you expect to find contracoup brain contusions? Visualize the momentum.
You'd find them on the undersurfaces of the frontal and temporal lobes. Revisit coup and contracoup injuries for the moving head paradigm.
Prompt 5. At autopsy, you find symmetrical anterior rib fractures with no surrounding hemorrhage in a victim who received emergency medical intervention. What is the most likely cause? Focus on the lack of hemorrhage.
Cardiopulmonary resuscitation, or CPR. Revisit chest injuries to review the vital reaction and medico-legal differentiation.
Prompt 6. Microscopic examination of white matter after a closed head injury shows accumulation of beta-amyloid precursor protein. What specific pathological process does this indicate? Think about the cellular level.
It indicates the interruption of exoplasmic flow due to diffuse axonal injury, or DAI. Revisit axonal injury for the specific timelines.
If you navigated those clinical vignettes successfully, your foundational understanding of regional biomechanics is solid. We have rigorously examined the structural and physiological responses of the cranial vault, the cervical conduit, the thoracic bellows, and the compressible abdominal core. The overarching principle remains the body physically records the transfer of kinetic energy. The pattern of tissue failure provides an objective, immutable account of the physical event. However, extracting that narrative requires a meticulous integration of anatomy, physics, and rigorous pathology.
A compelling final thought to consider as we conclude. Throughout the history of forensic medicine and jurisprudence, the narrative of an event has relied predominantly on human testimony. The fragmented memory of a witness, the potentially compromised statement of a suspect, or the inherently subjective interpretation of a scene. But the biomechanical and physiological markers we have discussed today operate entirely independent of human bias. A contre-coup contusion adheres strictly to the laws of inertia and deceleration. The accumulation of beta-APP follows an uncompromising biological clock. We currently rely on post-mortem pathological dissection to decode these absolute truths. But as functional neuroimaging and real-time biomarker analysis continue to advance at an unprecedented rate, we are rapidly approaching an era where the living brain can essentially testify to its own trauma in real time, long before a forensic pathologist is ever required. It represents a massive paradigm shift in the intersection of clinical trauma care and objective medical legal evidence.
The concept of the living physiology acting as the ultimate objective witness is profound. Thank you for joining us on this exhaustive exploration. For the medical students, surgical residents, and clinicians listening, carry these biomechanical frameworks into your clinical assessments, your surgical planning, and your forensic reasoning. The physical trauma always maps the mechanism. The diagnostic requirement is simply knowing how to read the terrain. Keep studying the underlying principles, maintain clinical precision, and we will reconvene for the next deep dive.